Good evening, all. Good evening, all Maha-APians and all viewers on Zoom and YouTube platform also. Good evening, today's experts, Dr. Y.K. Ambedkar sir, teacher of teachers, great human being, past CIP president, and second expert, Dr. P.G. Samdani sir, ex-honorary professor of Grant Medical College. Welcome, sir. Welcome from Team Maha-AP. I welcome today's moderators, Dr. Mahesh Moite sir, the man behind this Maha Case Challenge sessions. Then Dr. Sandeep Kadam sir, he is a renowned neonatologist from Pune. And I welcome all panelists, Dr. Nani sir, Dr. Naresh Taide sir, Dr. Chokhani sir, Dr. Subramaniam sir, Dr. Anjali Kokar madam, President of Palghar IIP, and Dr. Sudhir Sane sir, Senior Pediatricians from Thane. Maha Case Challenge was the idea of Dr. Mahesh Moite sir, and he discussed this idea with President Dr. Gangolia sir, and that was implemented through all Maha AP OBs who gave names of all participants and moderators, case moderators too. Session was ably coordinated by Dr. Sunita Ingle madam from Raigad IIP, then Dr. Shilpa Nambiar madam from Navi Mumbai, and Dr. Neha Singh, editor, and today's MOC also. I welcome all of you again, and I hand over to Dr. Neha Singh for further proceedings. Thank you.
Thank you, sir. Thank you, Amol sir. As we all know, today is the 9th and concluding episode of very successful Maha IP Case Challenge. Previously, we had 8 episodes with 16 interesting, mind-blowing cases, engaging 16 teams from different district and city branches of Maharashtra. And today comes our finale with so many dignitaries joining us today. I would request our Maha IP President, sir, Dr. Hemant Gangolia, sir, to give his blessings. Over to you, sir.
Thank you, Dr. Neha. Good evening and namaste, respected faculty, eminent experts, excellent panelists, extraordinary moderators, office bearers of Maha IP, Secretary Dr. Amol, Vice President Dr. Vinayak Patil, State Convener Dr. Jay Bhandarkar, Treasurer Dr. Mohan, all EV members of Maha IP, Chairman and Co-Chairman of Maha IP Women Committee, zonal members of Maha IP Women Committee, respected seniors, colleagues, all on the Zoom dais, as well as the viewers on the Maha IP YouTube channel. Well, as said by Dr. Amol, the idea of Maha Case Challenge was conceptualized by Dr. Mahesh Moite sir, and way back we had first of its kind during our COVID times when we had Paschim Rang, the West Zone Pedicon under the able leadership of the Dr. Dabarkar sir when he was Vice President of the West Zone 2020. And then we saw the same thing done at Maha Pedicon 2021 at Alibag when we had the third West Zone Pedicon and Maha Pedicon 2021. And when I took over as a president of Maha Academy of Pediatrics, then as a presidential action, we plan to have this Maha Case Challenge on every third Friday of every month since February 2022. And today is the 9th episode, which is the concluding one. And even all these episodes are there on Maha IP YouTube channel. One can go and just watch in the playlist of the Maha IP YouTube channel. I would like to thank heartfelt thanks to Dr. Mahesh Moite sir for his full support and help throughout the year for this Maha IP Case Challenge. As well, heartfelt thanks to the coordinators, Dr. Sunita Ingle, past IIP Raigad President, Dr. Shilpa Nambiar for all the communications and correspondence with all 16 districts IIP branches, this team, presenters, and for all 8 episodes as well as 8 experts across the country. And it was kept so secret, even myself and even Moite sir didn't knew at the beginning of episode which presenter will be presenting the case to which team. So the high level secrecy was maintained, and also the teams were informed 2 days prior that you are the team going to participate on this episode. And also heartfelt thanks to 2 more coordinators whose name I cannot take because of the election code conduct. Heartfelt thanks to all 16 district branches for a wholehearted cooperation. And I would like to name their branches: Amravati, Aurangabad, Beed, Dhule, Hingoli, Jalgaon, Kolhapur, Mumbai, Nagpur, Nashik, Navi Mumbai, Raigad, Pune, Palghar, Thane, Solapur. All office bearers of these branches teams and presenters from this team for the for taking the part in this MAHA-IP case challenge. As well as heartfelt thanks to Dr. Neha Singh for all this drafting all episodes of the fine appealing messages, WhatsApp messages. Thanks, Dr. Neha. As well as the man behind the screen, Dr. Vishal Raut, pediatrician from Rasaini. He made all the flyers throughout the year for MAHA-IP. I am extremely indebted to all MAHA-IP team, MAHA-IP 1 committee, Dr. Neha Singh, Dr. Vishal, and all the office bearers and of the MAHA-IP team and MAHA-IP 1 committee. Today, I cannot wish as I used to do in the past in all episodes, best wishes to the older teams, because today we have the galaxy of experts, titans to speak about and guide us how to approach the cases when we see in our general practice. Today is probably the ideal episode, and I will request afterwards when Dr. Mahesh Moite sir will take over the proceedings to say about this episode. When we had a talk, the week concluding episodes we should be having as an ideal one, what we should in our practice. And lastly, please excuse me for taking few minutes for this science, but felt it is equally important to acknowledge the efforts of the team behind all this array of activities which were carried out during this year throughout the years. Wish each one and happy learning. Thank you very much. Thank you very much.
Thank you, sir. As sir said, today we have a galaxy of experts, and the expert of expert is with us, Dr. Y.K. Amlekar, sir. He is ex-professor of pediatrics, Grant Medical College from Mumbai. He has authored few books and publications, Grand Rounds 1, 2, and 3, Steer, and the latest one is What Doctor Must Learn. Welcome, sir. We also have with us Dr. Prahlad Ghanshyam Samdani, sir, ex-honorable professor of pediatrics, Grand Medical College, emeritus consultant, Jasloop Hospital, honorable pediatrician, SRCC Bhatia Dalwai Hospital. Sir is pediatric consultant for last 52 years. Welcome, sir. And as moderators, we have with us Dr. Mahesh Moite, sir, pediatric and neonatal intensivist at Sai Child Care Clinic, New Panvel, Maharashtra at BJ Wadia Children Hospital, Mumbai. He is also chairperson 2022 IAP Intensive Care Chapter. He is teacher and council member of Pediatric Critical Care India. Sir has got PM Udani oration at Maha Pedicon 2021 and Dr. Sanjeev Rai endorsement lecture at CAR Pedicon 2022. Our second moderator is Dr. Sandeep Kadam, sir, DM Neonatology from Sion Hospital. He has done fellowship in neonatology, consultant neonatologist at KEM Pune, consultant neonatologist at MGM Pune since last 3 years. He has many publications and he has trained many students and all-time faculty of ventilation workshops. Now I hand over to Dr. Shilpa to introduce our panelists. Over to you, Shilpa.
Good evening to all the respected seniors. It was a great experience to be a part of this wonderful program. Excellent case discussions and differentials discussed in a very systematic format. I really thank our President, Dr. Hemant Gangulia, sir, and Dr. Moite, sir, for making me a part of this excellent program. So as we know, this time it's not a secret. We have all our panelists on the screen, and our panelists for today actually do not need any introduction as they are already legends in their own right. Still, I must do the proceedings. So firstly, we have Dr. Narendra Naniwadekar, sir. Sir is a practicing neonatologist and pediatrician at Niramaya Pediatric Nursing Home and Astradhar Hospital in Kolhapur. And he is the national convener. He has been a national convener of IAP ALS program and was the EB-CIIP member last year. Our next panelist is Dr. Naresh Taide, sir. Sir is a practicing pediatrician in Amravati. He has done special interest in clinical genetics and has done a fellowship in it. Sir is the president of Sickle Cell Association in Amravati. Our next panelist, Rajesh Chokani, sir. He's a practicing pediatrician in Mumbai. He has been awarded the GV Kopikar oration. in 2016. Sir has co-authored many books and has been the examiner and a teacher for all PGs like us. Next is Girish Subramaniam sir. Sir is a practicing pediatrician from Nagpur and has a experience of 25 years with special interest in pediatric rheumatology since the last 5 years. Dr. Anjali Gokarna ma'am. Ma'am is a practicing pediatrician in Vikas Children's Hospital, Vasai. She is the head of neonatology, DM Petit Municipal Hospital, and is practicing in the district of Palghar. Sudhir Sane sir. Sir is a pediatrician in Jupiter Hospital, Thane. He is the director of Jupiter Hospital, Thane. And he has done certificate course in infectious diseases and has a special interest in rational pediatrics. So this is the excellent team that we have for today's session. So let's start with the cases today. So I would actually request Dr. Mahesh Mohite sir to start today's case. And to take on today's case from Dr. Mahesh Mohite, I would request Dr. Rajesh Chokhani sir, Naresh Taide sir, and Sudhir Sane sir to please unmute.
So this was the secret, which team it is.
Small secret, sir.
Respected Ambedkar, thank you, Shilpa and Neha and Dr. Hemant. Respected Dr. Ambedkar sir and Dr. PG Samdani sir, both of our time great teachers. And Dr. Ambedkar used to have a silent clinical approach to its logical conclusion. And Dr. PG Samdani used to be called as king of spot diagnosis in our area, in our era. So we have two extremes of this, but believe me, we had huge kind of a, surprising kind of a diagnosis given. I still recall the kind of cases they used to diagnose in our days just on clinical examination days. And those days, the max investigation we had just come up CT scan, forget the MR and all. And these people used to just on the X-ray or first of all on clinical examination, most of the time used to crack diagnosis. About the faculty today, I was wondering what I'm going to present to them, because if I present something here, I feel Girish may crack it on the second slide. I present the other case, Rajesh may crack it on that. If I present the third case, Sudhir may crack it. So I was wondering how I'm going to select a case. So what I did is I took this first case. If it is cracked within 3 or 4 slides, then I have kept a standby case also, which will pull on by half an hour. So let's start with this first case. It's an interesting case. Who are taking my cases, Shilpa? You are muted, Shilpa. Shilpa, you are muted. I can't hear you.
Yes, sir. Dr. Rajesh Chokhani sir, Naresh Taide sir, and Sudhir Sane sir.
Fine. So all of us there, right?
Yes, sir.
Naresh and Sudhir, shall I start?
Yes, sir.
Okay, fine. Thank you. So here is a case. This is a 2-year-old boy brought for fever since 15 days. It was remitted moderate grade. Inter fever, the child was playful. He had cough since last 10 days, which was all throughout the day and night, sometimes wet cough. There was severe failure to thrive, frequent respiratory complaints and visit to doctor since last more than a year. He was born non-consanguineous, first child of the young couple. Birth weight was 2.8 kg, no significant antenatal, intranatal and postnatal history. Past history was relevant, so ahead of it. He has visited pediatricians almost every 15 days since age of 8 months and needed admission 4 times for respiratory complaints predominantly, though he had other ailments also. First admission at 7 months of life. With a history of Cox contact, some neighbor had Cox. They were not very sure, but they said very likely he is, because he keeps taking medicine and he keeps doing it, and very likely he has a Cox. They have heard from the family that he is on anti-Cox treatment. He's an elderly neighbor where child is taken very frequently and chronic patient on irregular treatment. He from lower middle socioeconomic class, approximate daily nutritional deficit of 500 kilocalorie and 10 gram protein. This is the deficit. Do you need any more information? Rajesh, Sudhir, And
So what kind of respiratory complaints was it that he needed admission? So was he becoming breathless? Was he having cough? Was he having cold, rhinitis along with that? So you said respiratory complaints. So would you like to magnify those complaints?
yeah, so he came to me for the first time at age of 2 years. Prior to that, he was following up at various places, Mumbai, Navi Mumbai, and he used to be taken to the doctor for cold, cough, fever, sometimes breathlessness. That's why he was admitted 4 times in the past. So they could not really specify. Yes, नाक भी बहता था, खांसी बहुत आता था, कभी कभी दम लगता था. That
And
is
in between the episodes, he used to be absolutely normal.
for few days, yes, but cough used to be there. Though fever was without, it's like every 15, 30 days, a month or something used to be there, getting these symptoms. And in between, yes, cough used to less, but never disappeared. Cough was always there.
Consanguinity.
Non-consanguineous.
And so, I mean, nutritional history you said, but breastfeeding and bottle feeding and immunization, was it, I mean,
Yeah.
contributing to his failure to thrive?
He was immunized to the date. Bottle feeding, yes, he was bottle fed, but breastfeeding was gone, was given exclusively for first 3 months, and later on was tapered off.
Okay.
And how was he in the first 7 months? You said the first admission was at 7 months.
Yes,
So
yes,
were there
yes. So
any
before that,
symptoms
no.
before
Before that, he did not have any significant hospitalization, though they did not have the weight chart and growth chart prior to that. But no significant symptom, no significant visits to the hospital prior to that.
So
Okay. So
Hospital admission, fine, but was he symptomatic or no? We don't know.
No significant symptoms. No, I asked that. So no significant complaints prior to that. So apart from immunization and occasional cold cough here and there, but no significant visits as such.
in this patient, as the complaints start at 7 months, and
Yeah.
as you say, the complaint are persistent, I may think there may be immunodeficiency as a component, as mainly they are the respiratory component along with the fever. So I want to know whether there is a immunodeficiency which may be primary or secondary. In the primary immunodeficiency, after 6 months, if it is presenting, then antibody mediated may be the more likely pathology. If otherwise he has also has a, if you say he has a chronic rhinorrhea and also had a cough, then I also can think of a immotile cilia syndrome. So I want to know whether there is a always there is associated rhinorrhea along with the cough, or whether there is a predominantly cough is the symptoms.
He never had any otitis media.
Yeah.
He never had any significant nasal discharges, as I asked him. And even on my admission day also, he didn't have a significant nasal discharge. Though the past, they are like any other parent, हाँ नाक बहता है, सर्दी आता है, you know. But he never had otitis media. He never had any purulent nasal discharges.
And what day the cord fall? Cord fall on?
No, honestly, I did not ask him.
Okay. So in this case, these are my differential. One is the immotile cilia syndrome, maybe cystic fibrosis as primary respiratory complaint is there. And along with the primary immunodeficiency, less likely as there is a history of contact, TB contact. So at the least likely, TB may be the another possibility. And along with, as 7 months the complaint is start, I don't know whether they at the initial of the episode, whether there is a episode which may suggest some foreign body. I want to know the symptoms, whether they are as a unilateral or bilateral, because if they are the bilateral symptoms and significant
Signs. You mean to say
bilateral
signs, right? That
signs.
will come to the clinical examination later.
And if he has significant respiratory distress,
Yes, 4 times he was hospitalized. At my place, he was, I will come to the clinical finding, but at least on the history, never admitted to the ICU.
okay. Okay.
Moite sir,
My-
Rajesh sir wants to
Mahesh,
say.
Yeah, Rajesh, I was just finishing with Naresh. Rajesh, please.
Yeah. So basically, see, the three big chief complaints are fever, cough, and breathlessness. Out of which, if we understand your history correctly, cough is the main complaint and more persistent or predominant than any of the other two. So that takes us to a primary airway disease as a first possible starting point. Now, when we, as Naresh just brought out about immunodeficiency and infections, so from your history, fever is not a very prominent or all the time complaint. So what I feel is that there are some infections that are happening in this primary disease intermittently, but not necessarily that infection is the main complaint. So I may keep immunodeficiency a little lower down. And the second issue about immunodeficiency is that it should be multi-system if it's a generalized immunodeficiency. So if at all, then I'm thinking of a local respiratory problem, which may lead to a local immunodeficiency restricting only to the respiratory system. Yeah, Sudhir.
So I wanted to take that point further, and I wanted to ask Mahesh that how was the child's development, and was there any gastrointestinal symptoms? So whether there was any symptoms involving
No significant
other system
gastrointestinal
and
symptoms.
developmental history.
Yeah. So
And
no
developmental history
significant
was
GI symptoms. Development history within normal limits.
okay. Okay. So that means I
And
think
if there is any polyuria also,
No history of polyuria. Why you ask that, Dr. Naresh?
because if we say that the respiratory symptoms are minimal and we are suspecting on allergic background, that severe failure to thrive cannot be explained with this only much with allergic explanation. So we have to have some systemic disorder which can have cause this much failure to thrive. I also
Are
want
we
to
really
know,
are we really thinking of allergic in this child?
no.
No one is thinking. Am I right?
Not allergic, but I think what
Airway.
Naresh is meaning is that only a airway disease to cause so much failure to thrive is unlikely.
Agreed.
So there has to be an extra component to it.
Okay.
And whether the patient also had a suppressed cough reflex cycle, or whether there is any episode of bluish discoloration of skin or lips at any time during feeding, or
No.
sometime
No.
like choking episode, etc.
No. Even though the past history we asked whether ever he was bluish on admission or so, they said no, even the doctor never informed them that child was blue.
Okay. And whether during hospitalization he required oxygen or he maintained without oxygen also?
Yes. Twice he required hospitalization, during which he required oxygen for a short duration.
Okay.
so.
At hospital, yes, he required oxygen.
So I would analyze it as a recurrent airway problem with secondary parenchymal involvement, which is happening often. So possibilities might be recurrent aspirations because of some problem. And one of the cause, that's why I asked about neurological involvement, because in a child who has got neurologically not normal, he may have recurrent aspirations because of palatophalangeal reflex. But otherwise, mechanical problems like S-shape fistula, I don't think it's a simple case of gastroesophageal reflux disorder, because that wouldn't cause such a severe significant symptoms. So something like mechanical S-shaped fistula, or again, we are back to whether it's a cystic fibrosis. Immobile cilia syndrome, yes, we should consider, but typically these children have a neonatal pneumonia of unknown cause. Typically, they have multiple otitis media episodes, discharging sinuses. And as Dr. Naresh was saying, that they also have thick nasal secretions, which said they are not. So I will keep that in mind, but lower on the card.
All those congenital anomaly, asymptomatic period of first 7 months, will you accept it?
So we know that S-shaped fistula can sometimes present later on, and that's the reason I think we
Shall I go for
should
examination?
keep that in mind.
Yeah.
Shall I go for examination?
Yeah.
Yes.
Right. I think they had a wonderful approach to it. Probably some airway disease, intermittent infections, could be congenital anomaly, and Naresh said could be PID, but then Rajesh and Sudhir have sort of kind of analyzed it further and said PID is probably secondary, right? So his vitals were stable, hemodynamically stable child, 120 per minute heart rate, CRT was 3 seconds, limbs were warm, temperature 100.6, he was febrile when he came to us. His conscious, irritable, oriented, well. His was tachypneic with intercostal, subcostal attractions, no stridor, no wheeze, no grunt. And this was his anthropometry. At 2 years, weight was 7.8, height was 70 centimeters, mid-arm circumference 12 centimeters, and head circumference 48 centimeters. General examination, there was no cyanosis, but saturation checked on pulse ox was 92% at room air. No lymph nodes, no rashes, no pigmentation, no other positive findings. Respiratory examination, he was tachypneic, 46 per minute with respiratory distress. All retractions were there. There was flattening of left hemithorax with decreased moments. Apex was left fifth intercostal space, mid-clavicular line, easily palpable. It was flat chest, as I said, flat and thin chest. Percussion, no significant difference appreciated between two sides. On auscultation, decreased air entry, left hemithorax, few creps scattered, increased VR in the retrocardiac region, and right side was normal. So all the findings were on the left side, right side was apparently all right. CVS apex was fifth intercostal space, otherwise normal. Do you need any more information? Rest of the findings were normal, other systems were normal, no organomegaly, no significant rash, lymphadenopathy, anything.
So you asked about, you said about clubbing. There was no clubbing.
No clubbing.
No clubbing. And the percussion node on the left side was dull.
Was nothing different much. As I said, no significant difference appreciated. But
Okay.
You could get the auscultation findings, decrease air entry left hemithorax, few creps, increase VR.
And just to complete the examination, the tracheal position was shifted to the left, or it was difficult to elicit because it's
could not appreciate very significant.
Okay. Okay. Yeah, Rajesh, you wanted to say something.
If we analyze the findings, both subcostal and intercostal retractions suggest, one, that there is some airway involvement for sure because there is subcostal retraction. Intercostal would mean parenchymal or interstitial involvement. Now, you said the baby is also hypoxic. So therefore, there is some involvement at the terminal part of the, the airway, where the airway meets the interstitium parenchyma. There is some involvement there. Flattening of the left side in the absence of your change in note suggests that there is fibrosis, and therefore, and those scattered creps also would suggest possibly some fibrotic element. So over a period of time, whatever pathology is there at the alveolar interstitial terminal airway region is causing some fibrosis. My only problem is because it is unilateral. That is odd, because all these problems should usually be bilateral. They shouldn't be unilateral.
Naresh, please.
I am worried about this patient. He is 2 years with 7.8 and height is also 70 centimeter. So this may make me think with this unilateral finding why he is a so severe failure to thrive, which cannot be explained with unilateral finding. And I want to know what is his birth weight, and if possible, if he has look like other normal child at birth, or he looks small like than the other child at birth.
He was not noticeably small for gestational. In the sense, they didn't know the weight exactly, but they said he was average.
Okay.
So with these kind of findings which are restricted to left hemithorax, which has fibrosis with collapse, with airway and parenchymal disease, I believe that it's an airway disease which started first and led to subsequent parenchymal disease and collapse and fibrosis. So there are two possibilities. And as I think Dr. Naresh right in the beginning said that the symptoms started at 7 months. So was there a foreign body, and therefore airway obstruction and subsequent now the recurrent problems which is partially causing. And second thing is that tuberculous lymph node which is causing compression and endobronchial tuberculosis with this vague history. These are the two possibilities after examination I will give.
So the whole history is almost 1.5 years. Do you expect the tuberculosis to go like that?
In a malnourished child, a tuberculosis can have a varied presentation.
And he hasn't received any significant AKT so far.
Yes, but multiple antibiotics. So that's why the first diagnosis would be, I mean, we should think of airway disorder, then whether there is a foreign body, but there is no significant history of that as of now. And therefore, these two differential diagnoses, I know that. So in malnourished child, tuberculosis can behave, uh, can have a varied presentation, and therefore we should just keep that in mind. I feel.
So we have two, three possibilities here. Yeah, you want to add something?
I also want to know whether he has any lymphadenopathy, whether he has BCG scar mark which is present or not, and whether he has abdomen, means hepatosplenomegaly or any other organomegaly or not.
No organomegaly, no lymphadenopathy. BCG scar was there and normal.
Okay.
And so here we resolved that it is very likely airway disease which has progressed to parenchyma. It is unilateral, so thinking of Cox, but then looking at the prolonged course, a bit unusual and has not received any AKT so far. It looks unusual. Shall we move further? You want any more information at this point of time?
No.
So here we are probably airway disease with a recurrent kind of a problem. And immunodeficiency we are keeping lower down again because not a bilateral, it's a unilateral and no other systems involved so far. And severe malnutrition probably suggesting that the problem has started very early in the life. It is not a recent onset problem. It has started very early. Even the length is just 70 centimeter, weight is very low. Investigation. We got only the present illness investigation. The previous file was not available, whatever. I mean, they have been moving, but unfortunately could not get all the code. So present, it was looking like a bacterial count overall. Now we had come with 15 days history of fever. So 16,800 neutrophilic count. Urine was normal, LFT, KFT was normal. And this was his X-ray.
So you want one of us to read the X-ray, Mahesh?
You can, yes, definitely.
Yeah. So I think there is a definite homogeneous opacity, not heterogeneous opacity on the left hemithorax, and signs of pulled left upper diaphragm. There also seems to be compensatory emphysema or shift of the left right lung is probably coming on the right side. The heart shadow is not clearly manifesting, and I can see thin line of pleural line on the lateral hemithorax. So I can see that there is some thin line here, which
Yes.
Lateral side hemithorax.
This
so
one?
I think yes, correct. So, and whatever is the lung parenchyma which is seen inside the opacity seems to be kind of abnormal lung parenchyma. So that is what my so again, collapse, consolidation, effusion, so something like that, and a massive collapse. So that would be the.
Any addition? Anybody wants to add anything? Dr. Naresh, Dr. Rajesh?
Yes.
Or shall I move ahead?
Whether this shadow, whether the intestine also in the hemithorax or
which one?
Because
this one?
This one, right.
What do you think it is? It's the intestine you feel?
No. They are not there.
This one?
This one. Whether there is, because we cannot trace here the continuity of diaphragm in the. So what is the abdomen of this child? Whether there is scaphoid abdomen? The child
not really. It was not scaphoid.
Okay.
And you can see the stomach in position.
Yeah, stomach in position, but this I am not able to, whether there is is going from, and trachea is also shifted to.
Yeah, it is shifted to.
Yeah.
But that is because of the collapse.
Yeah.
Collapse consolidation.
Right.
And there is slight, you can say the malrotation, and it's not centralized all that well.
So as Dr. Sudhir has already said, the possibility of something compressing and or some foreign body, we are still, and sometimes some mucus plug, which can again explain this. So if we have a cystic fibrosis and causing mucus plug, this may be sometimes we can get the picture, but most probably every time this much unilateral, I cannot explain on this.
Cystic fibrosis is now unlikely because it cannot be unilateral. It will have to be bilateral. So therefore, it has to be a local problem. So there is either some local obstruction or local congenital malformation or something like that.
Right, sir. Right, sir.
Shall I move further?
Yes,
Shall
sir.
I move further?
So can I say something? So yeah. So what would be
Yeah.
okay? So my next investigation in this case might be to confirm that pleural shadow whether there is pleural effusion, because for me that would actually give a real differential diagnosis. Which these two cases that I have, that if it's a tuberculosis, then a pleural effusion can still be explained. So many oddities I know, but still it can be explained. But if it's a foreign body, then it will be difficult for me to explain that pleural effusion. So my thinking would be to do sonography of the chest to see what is there.
Okay. I'm sorry, I will have to perhaps stop sharing and come back again because the slides are not moving. I'll just stop sharing and come back again, right?
Yeah,
Just
don't show us the diagnosis.
no, not at all. I will never. It's really getting interesting now, right?
Yeah.
Yes.
It's quite not moving.
Go to the next slide, Mahesh, and then start sharing.
Yeah, I'm trying that, but it's not.
No, stop sharing. Go to the
Ha.
next slide. Come out of the PowerPoint presentation mode.
Okay, fine. I'll come out. One minute. There is something has gone wrong on side. Yeah, 1 minute. Can you see it now?
नाही सर नाही दिसत आहे.
नाही दिसत
नाही
आहे?
दिसत आहे. हा नाही.
शेअरिंग परत करावं लागेल सर.
परत शेअर करा आणि
हा,
त्याला
हा.
डबल टॅप करा. ते स्क्रीन हँग झालं.
एकच मिनिट. हा.
हा सर, आता शेअर झालंय.
येस येस.
शेअर झालंय सर, आणि नेक्स्ट स्लाइड पण आली. फक्त स्लाइड शो करा सर, म्हणजे फुल स्क्रीन.
Perfect. आला था? आता
Yes,
right?
sir. Yes, sir.
Fine. So what is DD so far?
So again, a unilateral lung disease, fibrosis, collapse, possibly pleural effusion associated, and it seems to be a chronic illness which is restricted to that side. So our differential diagnosis, my differential diagnosis will be again, if it's a foreign body, which is a neglected foreign body causing the problem, any extrinsic airway compression, including tuberculosis in the relevant history that is causing the problem, and whether there is, as Rajesh has brought out, whether it is any congenital abnormality. So what congenital abnormality will come with pleural effusion? Maybe something to do with thoracic duct or something like that. So I would just keep those things in mind, kind of vaguely. I'm not very sure which congenital abnormality causes thoracic duct obstruction, but I will keep those things in mind.
Just one question to all three of you. Will you still keep TB as a differential in this child? 2 years old. Whole problem looks to be really 1.5 year old. And no AKT received so far. There is a Cox contact.
So to argue, I will still keep that in mind, especially with that pleural effusion there, for 2-3 reasons. One is, as we discussed, that a malnourished child can behave differently. This child must have received multiple antibiotics, and some of them can have partial anti-tuberculous activity. We know amikacin, amoxiclavulinate, all those things have. Even some people might give fluoroquinolones, and all this might have partial anti-tuberculous activity.
Naresh, you are saying something?
No, sir. I am agree with that. I also kept the TB as one of the diagnosis, and
Very
it may
good.
be associated with the HIV also. So we are
So
missing HIV here. HIV can be maybe combined with TB. Okay,
Good one.
because he has a
Excellent.
failure to
Excellent.
thrive. I am not still able to explain unilateral disease and why he has so much failure to thrive with so much short stature. I am with the localized disease. I am not able. Foreign
So
body will
what
also.
next investigation you want at this point of time?
I have to do his of his USG as sir had says, to look for the whether there is a pleural effusion or all that other things, to look for the respiratory physiology,
He
gastric aspirate lavage,
he was
HIV.
he was referred to us from a center where instead of USG they had done a CT looking at it, and CT was not showing any pleural effusion.
Okay, so
I show you the CT picture, not very clear, but one picture I could get from my archives. Okay, so
Okay.
gastric lavage was done by referring unit, which was normal. Tracheal aspirate was done by them, and CB-NAT was weak positive, rifampicin sensitive. What next?
So I think weak positive CB-NAT is always, there is a catch there, because there the CB-NAT itself, although we believe that it is very highly sensitive and specific, but there can be still 5% false positive, and therefore here, if this CB-NAT is weak positive RIFA sensitive, and with my diagnosis, I might think that, so tracheal aspirate means they did, what did they do? They did
They
endotracheal intubation and
They
aspirate.
intubated and they pushed in small saline and they got it sucked. That's a tracheal aspirate.
Correct. So with that, I'm sure that it must have been sent for culture and
Yes.
culture.
Yes.
So waiting for culture, and as Dr. Naresh rightly pointed out, ruling out retroviral infections, I think I will take it as tuberculosis. But I will still like to know what pathology it is, why this tuberculosis is affecting unilaterally this child. Is there a lymph node which is compressing? It is endocardial tuberculosis. Yeah. So I will put this child
Waiting
on
for
cold drug
his
primer.
culture. Yes, waiting for his culture. The previous center had already started him on AKT for last 2 months, and there was no clinical response. So they're waiting for culture. Now, child was suggested CT thorax before coming to us for any lymph nodes or any kind of missing there. Not very good picture, I would say. I didn't put the other things, but there are no significant lymph nodes in the mediastinum, no caseating lymph nodes. And this is a picture, as you see it, there is no pleural effusion also. There was patches of collapse consolidation, and even bronchiectasis is set up in those lower areas. So that is a picture. He came at this stage to us. What next? Wait for TB culture, repeat valve, anything else? Yes, Sudhir.
So all the time, right from the beginning, I'm thinking of extra bronchial compression, like lymph node, which is causing the problem. But there is no lymph node, so that looks unlikely. So whether it is endobronchial problem now, so whether it is tracheal stenosis, anything local tracheal problem, and therefore at this stage, if the child is not improving, then my first thing is that I will do a bronchoscopy and I will see what is happening on the left side, whether there is a local abnormality, whether there is scarring, whether there is caseation that is causing the problem. All other, Rajesh and Naresh, you can comment.
Rajesh, Dr. Naresh, you want to add anything?
So, yeah, I thought bronchoscopy is the next best step.
Perfect. I think
Bronchoscopy,
you are
and
absolutely there.
along with that, we want to do the all systemic screening like LFT, RFT, all these
We
things.
did that. We were all normal. And what you expect in bronchoscopy, can you just repeat once? You're looking at possibly endobronchial. Any other possibility?
So tubercular scarring, a stenosis, or maybe even congenital problem. So that's the thing that we are thinking.
We are absolutely on that. Only thing is whether it is TB, and this is a bronchoscopy. And you can see that very clearly. What was it? It was a H-type tube fistula. So moral of the story, history taking is far more important than the clinical examination. It was a H-type fistula which was missed all along. You can see that fistula. You can see that. This is a fistula. This was the H-type fistula which was missed all along. And then going back to the X-ray again, what Dr. Naresh said about the intestine, And this case was presented in one of the forums, and a brilliant radiologist from SRCC had pointed out that this is a dilated esophagus. Normally, you never see the esophagus on a CT, on a chest X-ray. You see dilated, assume that there is some gas trapped inside. And one of the ways of gas trapping is through a step tissue, fistula. With that, you are seeing a fully bloated stomach. So this child had history of persistent fullness and decreased appetite because of that. So combining the two, he on the X-ray had said that very likely this is H-type fistula. So it was very something which I rarely saw. A dilated esophagus in the chest X-ray is one of the features of H-type fistula. So bronchoscopy H-type TO fistula was confirmed. What were the clues? Prolonged history since infancy. So correlate with the congenital anomaly likely. Doubtful labs, limitation of gene expert, as Sudhir already said, we do nowadays gene expert ultra, and the sensitivity is to the tune of 16 bacilli, unlike the older one, which was 133 bacilli or something. So today we are picking up 16 bacilli. So even a dormant dead bacilli gene can be picked up in that, and that can give false positivity. Persistent shadows and complaints going on a one side doesn't, I mean, almost rule out the generalized pathology. And always when it starts early in the life, think of congenital anomaly. So bacterial diagnosis is very important for COX, and we all need to get that. We cannot be starting straight away on empirical COX. I'm sure Dr. Ambedkar sir has always taught us over 30 years. There is no empirical AKT. And this was even before we used to diagnose. Nowadays, we get a bacterial diagnosis very often. But those were days, if the empyema don't respond, start AKT. The abdomen can continue to start AKT. Those are the days. And then that's where it's important of diagnosing bacterial diagnosis. But at the end, not to forget, Sudhir, on the third slide, had said very dogmatically, this could be H-type fistula. So think of that. I think you have made it the day. Thank you very much. Your last comments again.
So I think I just wanted to know that after getting the diagnosis, Mahesh, did you go back to the case and ask for recurrent aspiration during feed? Because
we did.
If that is happening, then
No,
that's a clinical this thing for.
No, there are no such
there was no
need. There was no need. And first 7 months, the child was asymptomatic overall, never had an aspirate. So the comments are Dr. Ambedkar sir and Dr. Samdani sir back to back, and then we can move to the next case. Sir Ambedkar sir, please.
I think 2-3 things would be important to begin with. One, the story started at about 7 months of age. So we must try to make out as much as possible whether the child has been all right till that time. Now, obviously, there may not be a wet record to substantiate that, but at least what was the activity like? What was the happiness like? What was the playfulness like? So we get some idea whether the problem really started not since birth, but a little later. That is number one. Second is, whatever is the congenital malformation, the infection gets under control, though the cough may not. And to that extent, the period in between 2 episodes of fever are not so bad. Whereas, if there is a persistent disease, like a CF, immunodeficiency or whatever, then the possibility that the infection doesn't clear off at all. So between these two conditions, obviously, you have a unilateral problem. Now, unilateral problem going on for a long time is very unlikely a primary infective disease, but possibly localized secondary infective disease. That's number one. But Mahesh, I did not find, obviously, that you said there was a diminished air entry and flattening all over the left hemithorax. Now, yes, what was the mediastinum like? What was the trachea like? Was it shifted at all? It should have been greatly shifted either way, one way or another. If it was not, so then that's very unusual. That suggests that your problem is not entire lung, but patchy disease. Because had it been an entire left hemithorax of whatever kind, you would have expecting definitely a mediastinal shift or a tracheal shift as well, which was not there, which puts me to feel that this is not uniformly all over. As much as we were thinking about obstruction to the main bronchus, that would have caused signs all over the same. You also had a bronchial breathing increase VR at some place, which itself meant that the entire hemithorax was not involved, but it was a patchy involvement. The flattening suggests it's a chronic problem, either fibrosis. In fact, fibrosis is more common when there is a flattening rather than a collapse. And the collapse in this child has not been really a massive collapse. So it is really a persistent inflammation, infective as well as chemical, that has led to fibrosis. So I think coming back to that, I would have started thinking how well the child is as far as fever is concerned in between two episodes, because the infections are not difficult to control in a congenital malformation, though they may be recurrent. Whereas if there is a persistent problem like a CF, immune deficiency, whatever, it's not easy to control infection itself. So I think that would have been, of course, partly. I recall this case at SRCC where our radiologist pointed out a dilated esophagus, and that took away the whole thing. But as you started presenting, not knowing what you are going to present, I would have started thinking the difference between a persistent disease and a recurrent disease should be first tried to make out. Any mechanical or a chemical problems are recurrent, and any infection, whatever the cause, is persistent. So I think that could have been just a possible thing. But yes, that X-ray possibly got into it, right? Thank you.
Sir, can we take one more point here, that recurrent problem over the time can develop persistent shadows, as in this case? Yeah, and develop persistent shadows.
See, the point is, don't go only by the weight or length. Okay, go by how playful is in between infections. That is important. See, he has a stomach problem that's all bloated. Okay, so that's one reason why he's possibly not feeding adequately and he has a reasonable deficit of calories. But I would have expected him to be playful in between. If not, then he has a persistent problem. I think we are just learning how much in depth we could go between recurrent and persistent. If it's recurrent, then it's not a primary infection. If it's persistent, then there's a background cause of persistent infection. Right? Thank you.
Samdani sir, quick comment.
Yeah, I think I must congratulate for the diagnosis of making an H fistula. Now, there are 2 or 3 points. When you talked about immunodeficiency, nobody talked about presence or absence of tonsils. Absence of tonsils will give you agammaglobulinemia and immunodeficiency. So that rules out at that level only, because the tonsils are visible and well. Number 2, nobody gave us a history that what are the X-ray pictures of the past, where 4 times he was hospitalized. If it is coming to the same site infection, then you know it's a local problem, which makes H fistula or a congenital anomaly is the highest on card as compared to immunodeficiency. Number 2, this child did not have clubbing, did not have GI tract symptoms. Therefore, cystic fibrosis goes out because it is unlikely to have that. And therefore, with these, and nobody talked about any male member died of any infections repeatedly. It talks about agammaglobulinemia, X-linked. So these will eliminate such diagnosis or differential diagnosis at the earlier stage.
Right, sir. Excellent. Thank you. Over to Neha, Neha Shilpa for the further proceedings.
Yes,
Thank
sir.
you very much, all the faculties. Wonderful crack. Excellent discussion. Thank you very much. Next.
Excellent case discussion, sir, and very well dissected and discussed. We'll move to the next case. Dr. Sandeep Kadam, sir. Yes, sir. And to take the case, Dr. Girish Subramaniam, sir, Anjali Gokarn, ma'am, and Nani Wadikar, sir, can you please unmute yourself?
Respected Ambedkar sir, respected Samdani sir, members of the Maharashtra State IIP, office bearers, Dr. Moite sir and Dr. Abasai Patankar. Thank you very much for giving me this opportunity to be here with this evening with all of you. What we are going to see is a case which presented to us. One second. This was a 6 weeks infant who was referred to us for jaundice since day 1 of life. This baby was born to a mother who was 28 years old, gravida 2, para 1, living 1, and this was a full-term pregnancy. This was a non-consanguineous marriage. The mother's blood group was B negative. The first child is a girl child, 5 years old, doing well. Her blood group was RH positive, and the mother had received anti-D after that delivery. This pregnancy, the mother was antenatally registered, immunized with DTAP. The ultrasound was normal. This baby was born at term. It was a normal delivery. Baby cried immediately after birth. The weight was 2750 grams on 20th of July 2022. Mother's blood group, as I told you, was B negative and the baby was B positive. This baby was born at a very peripheral taluka place, and the obstetrician noticed that the baby was looking yellow at 22 hours of age. Started phototherapy, but at 28 hours, the bilirubin was done and it was 14, which increased to 19 milligram per deciliter at 34 hours and was referred to a neonatal ICU in the close by district for exchange transfusion. The neonatologist started intensive phototherapy, which was a triple surface phototherapy. He gave a dose of immunoglobulin, 1 gram per kilo, and the repeat serum bilirubin was 17 milligram per deciliter with direct fraction of less than 1 at 40 hours of life. And since the bilirubin was showing a declining trend with intensive phototherapy and VIG, the phototherapy was continued with hydration. Adequacy of phototherapy was monitored, urine output was monitored, the baby was feeding well, and the neurological examination then was apparently normal. So the intensive phototherapy was continued. Bilirubin showed a declining trend. Baby was neurologically normal. Discharge on day 6. OE done at the time of discharge was normal, and the baby was discharged home and the mother was confident of feeding, and since it was a second gravida mother. However, this baby again presented to the same neonatologist on day 20 of life. Here, the mother noticed that the baby was looking increasingly pale, and the baby had shown a weight gain of 400 grams. The weight was 3.1 kilo, head circumference was 33 centimeter. The baby looked pale and the baby was icteric. The baby was feeding well, activity was normal. Baby had a spleen of 1 centimeter, liver of 2 centimeter, and the urine was normal colored, not staining the diaper. The stools were yellow. In this admission, the neonatologist had seen that the hemoglobin had reduced to 6.9 gram per deciliter. The WBC count was 12,400 per cubic millimeter. Platelet count was normal. Peripheral blood smear showed hemolysis. The Coombs test was positive. Serum bilirubin was 8.9 milligram per deciliter. Direct fraction was 1.6. Baby received 2 transfusions, and the baby was discharged on third day of life, on the third day of admission, that was on day 23 of life, and was advised for repeated follow-up with a clear idea that the hemoglobin may fall, so one needs to monitor. And the baby was otherwise doing well and was discharged on supplements. On follow-up, the baby presented to him at day 48 of life with abdominal distension, urine which was high colored and yellow and staining the diapers. In view of increasing jaundice, the baby was referred to us at KM Hospital, Pune. So, shall I proceed, or you have any questions till now?
What was the serum bilirubin or the first time of discharge?
Here we had, this was a
day 6
investigation which they had done.
Discharge on day 6.
And this was the second admission. It was 8.9. Acha, the first admission that he had.
And
the bilirubin, the bilirubin which was done here was on day 5, that the discharge card mentioned the bilirubin was reduced to 10. So and that's why the baby was discharged.
And the hemoglobin then?
Hemoglobin was 11 grams.
Even then, okay.
Yes.
Yeah, okay. And second time post transfusion, how much was the hemoglobin?
Hemoglobin had increased to 12.5. And the bilirubin at that point in time was 8.9, so they had not repeated it.
And any other LFTs were done at that time?
No LFTs were done. The records did not mention any LFTs.
And can we know the MCHC when this hemoglobin CBC was done?
No, it was not. We did not have any details of the reports.
Okay.
But these were mentioned on the discharge card. That's why.
Okay.
So do you want to analyze at this point of time?
Yes, I think initially the baby has had typical RH incompatibility type of jaundice, which probably has responded to the phototherapy, and the child started doing well over a period of time. Initially, there was no staining of diaper. The child was passing yellow colored stools, and the child was having urine which was not dark colored. So phototherapy and exchange was not required, right? So over a period of time, this has settled down. But now the second admission which has come up, the child is showing a change in the trend. Now the child is going into probably the urine diapers are getting stained. So what is the stool color now on this second admission? With this,
it was pale yellow in color. It was pale yellow in color.
So probably there is a change in the color. So now, and if we can see, although 1.6 is not very high direct bilirubin, but there is definite change over, because the initial direct bilirubin was 0.6, and now it is coming to 1.6. So there is definite probability that we are going into the obstructive type of or cholestatic type of jaundice. Both the things probably may not be correlated at this stage.
Yeah, it could be. Can I say something?
Yes, madam.
Yeah, it could be correlated because following RH incompatibility, sometimes there is inspissated bile syndrome, which can happen, and that can lead to direct hyperbilirubinemia. Of course, there was no direct, but the pale colored stool can be explained. So even at 28 days of life, it did look like, but although it is a little too late for, so there was some ongoing hemolysis.
Absolutely agree with you, madam. That is what the treating neonatologist probably thought. So that's why he wanted to follow up rather than investigate. So they followed up. But however, on the baby presented to him at day 48 with a clear abdominal full distension and the urine which was yellowish and the jaundice which looked slightly more. So they have referred the baby to us.
Just to break you here, Dr. Girish is also a panelist. Dr. Girish,
yeah.
participate?
Girish wants to say something.
I think it has already been said by the other panelists. Presenting as an indirect hyperbilirubinemia, and now direct hyperbilirubinemia. The first diagnosis that comes to mind is inspissated bile syndrome. But it was as simple as that, then Dr. Kadam would not have been presenting this.
No, I think
Sir,
I would like to just say that in today's time, it is very difficult to analyze a simple case. Most of us probably get attracted towards rare cause, and which we don't see in a day-to-day practice.
Instead of inspissated bile syndrome.
So I totally agree with you with what you are saying, that obviously this was an RH isoimmunization which looked like a very high indirect, now going into inspissated bile syndrome. So absolutely spot on.
But I'm sure you'll have a twist in the table.
let us see what the baby taught us, sir.
Yeah.
So this baby on day 48, when the baby came to us at KEM hospital on assessment, on clinical examination, the baby was having pallor. The weight was 3.8 kilos, length was 54 centimeter, head circumference was 36.5 centimeter. On clinical evaluation, there was no cataract, there was no chorioretinitis which the ophthalmologist could see. There was no facial dysmorphism. However, the baby definitely looked pale. There was jaundice which was present. The baby had put on 700 grams weight in 28 days, which was about 25 grams per day. There were no rashes. There was no evidence of any coarse features. The genitals were normal. The baby did have hepatomegaly, 2 centimeters below the right subcostal margin. It was firm in consistency, slightly tender. The liver span was 6.5 centimeters. Spleen was 1.5 centimeters below the left costal margin. There was no murmur. There were no abnormal heart sounds. The air entry was bilaterally equal. Anterior fontanelle was leveled. The baby did have a tone which was normal, and the neurological evaluation was normal. The urine was staining the diaper. The stools were pale yellow in color. So any comments on this by anyone?
So this looks like direct hyperbilirubinemia with anemia So there is some ongoing hemolysis as well as some kind of stasis, cholestasis.
Yeah, absolutely, ma'am.
And no coarse features, no dysmorphism, so no cataract. So all these congenital infections seem lower. So it's not going typical like a neonatal hepatitis syndrome. So some
Yeah. Yes, Nanivadekar, sir.
yeah, this is all. So nothing to add after this.
So he
Girish,
has
sir.
ruled out galactosemia very categorically.
Yes.
And other congenital infections.
Yes.
Girish, sir, any comments, sir?
What
You can't rule out cataract and chorioretinitis on clinical examination.
No. The ophthalmologist did not see any evidence of cataract or chorioretinitis. So I just wanted to give you some information.
Right.
Yeah.
Doesn't rule it out yet. It makes it unlikely.
Okay.
Okay.
So at this point in time, our problems were more of anemia. There was jaundice, which looked like a conjugated hyperbilirubinemia. There was definitely hepatomegaly and splenomegaly. So we were looking at differential diagnosis at this point in time. And as all of you, this started as an RH organization, had hemolysis, looked like a inspissated bile syndrome. Now the baby started looking to have cholestasis with hepatomegaly, splenomegaly, and anemia and jaundice. So are we dealing with something which is not just hemolytic anemia, but something beyond a hemolytic anemia, which we would like to analyze? So what we did was we investigated this baby, and the hemoglobin was 7.3 grams per cent. Again, the hemoglobin had definitely showed a decline. Total counts were normal. The platelets were normal. SGPT was 213 with a serum bilirubin of 9.3 and a direct of 6.19. Indirect was 3.02. Gamma GT was 978 units per ml and the INR was 1.2. Serum protein showed albumin of 3 and a globulin of 1.9. Retic count was 5%. As I already told you that the DCT was positive. Peripheral blood smear showed hemolysis. Thyroid functions were normal. Urine culture was normal. Any comments?
Urine non-glucose reducing substance was done.
Negative, sir.
Cholesterol?
We had not done cholesterol. So this is looking more like a mixed hepatobiliary, hepatocellular as well as a biliary canaliculi problem, as well as there is some ongoing hemolysis that is a little bothersome. It doesn't fit into just a liver pathology. Maybe there is something systemic going on.
How old is the baby now?
So this was on day 48. So we roughly around 48, 50 days.
And this child has gained weight, right? 700
Yes,
grams.
700 grams.
This is IgCT neonatal cholestasis syndrome.
Yeah.
Three or four conditions that need to be thought about are biliary atresia, Palagili syndrome, and I think it is type 3.
PFIC.
PFIC also we have to keep in mind.
PFIC.
Yeah. So,
yes.
So we were looking at probably some obstructive element, maybe PFIC3, maybe biliary atresia, maybe biliary hypoplasia. Did not look like a syndromic biliary hypoplasia, maybe a non-syndromic biliary hypoplasia. Yeah. So let's see what the story now unfolds. Ultrasound was done, which showed hepatomegaly, distended gallbladder, spleen which was enlarged, minimal fluid. The baby was started on vitamin A, D, E, and K, and we started with ursodeoxycholic acid orally. Baby received one transfusion in view of anemia, and the baby was discharged on day 51 of life. As the baby was feeding well, the mother and the father were counseled regarding the progress of the disease, regarding the need for follow-up. And since the baby was otherwise looking well, we thought we would wait rather than do further invasive investigations with a very close follow-up, and in case of any high-risk problem, to come to the hospital in emergency. So this baby came back to us on day 70 of life. That was on 28th of 9 with complaints of increasing jaundice, but the abdomen was quite distended according to the mother. There was decreased feeding and mild breathing difficulty since the last 2 days. So they came basically with a lot of abdominal fullness and jaundice and breathing difficulty. The baby did look slightly more yellow, and this was on day 70 of life. The baby's weight on admission, this was the second admission, was 4 kilos, which was less than the third centile. We had put just 200 grams weight gain in days, which was quite less. Head circumference was between the third and the 10th centile, 37 centimeters. Baby had pallor. The jaundice did look more. The liver was enlarged. It was firm in consistency, 3 centimeters below the costal margin. The liver span was 7 centimeters. Spleen was 2 centimeters palpable. The umbilicus was transversely stretched, and there was fluid thrill which was evident, and there was ascites which was present. So any comments?
Now this albumin at this point of time.
Pardon?
Albumin at this point of time.
Albumin. I'll come to the investigations, but these are the clinical findings.
Yeah, this now probably is progressing towards more severe liver. It's almost like going into severe liver cell failure, whatever the pathology is. And this time the ultrasound, there's no comment on the gallbladder, the size or the distension, and anything else seen in the gallbladder.
No, I will come to the investigations in a while, but I thought, before we go to the investigations, on the clinical grounds, any comments from any one of you?
Considering the ascites at this point of time, I think we can broadly differentiate into 2 categories. One, acute liver failure occurring at such a young age. And the only other condition where you will have neonatal cholestasis with ascites at this age is spontaneous perforation of the bile duct.
Yes. The child will be too toxic for that.
Pardon?
May not be very toxic, but spontaneous perforation of the bile duct is one condition where you can have ascites, biliary ascites very early in life, and neonatal cholestasis.
So the problems were increasing jaundice, hepatomegaly, splenomegaly, ascites, and anemia. Hemoglobin was 7.5 grams. TLC was 7,900. Platelets were normal. SGPT was 127. Bilirubin was 9.28 with a direct of 7.04. Albumin was 4.3 with total proteins were 4.3 with albumin of 2.6. PT was 21 for a control of 11.8 second. INR was 1.76. PTTK was normal. Ultrasound showed coarse and bright liver, hepatomegaly, splenomegaly, ascites, and prominent biliary radicals. The gallbladder was apparently normal. It was slightly distended. The ascitic tap was done, which showed 248 cells. 10% were polys. Protein was 2.1. Albumin was 1.6. LDH was 147. No malignant cells. Cultures were negative. Serum ascites to albumin gradient was 1.5, 1.57. So any thoughts on this? Do we think that this is a worsening liver disease that we are looking at, which has decompensated over a period of time? Or do we think that this is...
whether there is some portal vein, how is the portal, veins?
The portal vein caliper was normal. There was no evidence of any thrombosis.
Yeah.
That they could see.
Okay. And why is someone commenting? Okay. And yeah. How was the general condition? Feeding? Was there any abnormal smell to the urine at this
There was
stage?
no abnormal smell to the urine. Urine culture was normal. Urine routine was normal, except there was obviously bile salt and bile.
Yeah. What about the other?
biliary radicals. He's talked about prominent biliary radicals. So
Yes.
that
yes.
will everything. And now, what is the color of the stool? Has it still remained pale yellow? It has turned to clay white.
The stools were pale yellow in color. They were not white.
Okay, so there is no complete obstruction. So total obstruction or obstructive area seems to be less. But
ascitic fluid bilirubin was done.
Yeah, the
Ascitic-
bilirubin was done.
Ascitic fluid bilirubin was done, and it was showing a level of 5.7.
Hemoglobin 7.3 was GPT was 2.
So I think these were the charts that we would like to see when we just took. I thought I would compile the investigations that the hemoglobin and 2 admissions were low. The SGPT, which was 213, had reduced to 127. GGT, which was 978, was 513, and bilirubin was more or less conjugated. Serum proteins were marginally less in the second admissions. INR was 1.2. It had gone up to 1.74, and then it was 1.14. And the ultrasound showed these pictures. So if we look at the timeline, on day 1, this baby presented with hyperbil, had anemia, discharge on day 6 with intensive phototherapy and IVIG, presented to the neonatologist on day 20 for anemia, received 2 transfusions, had slight jaundice, but the baby was asked to follow up. At day 48, the baby came to us at KEM again for anemia, direct hyperbil, hepatomegaly, splenomegaly. It was given 1 transfusion and discharged. But day 70, this baby came to us with increasing jaundice, conjugated hyperbil, anemia, hepatosplenomegaly, ascites, and was discharged on day 84.
And discharged on day 84. Okay, he
Yeah.
got okay.
Serum ferritin was done.
Serum ferritin was 264, sir.
Very high.
But maybe there were too many blood transfusions. There was so much of ongoing hepatocellular disease.
Were any tests for inborn errors of metabolism done? Did you do any urine GCMS or?
We have not really sent any metabolic workup.
Okay.
That seems.
And what about HB electrophoresis?
There was a RH incompatibility, so we did not think of anything beyond RH, because the mother was negative, baby was positive, the Coombs was positive, so it was an immune-mediated hemolysis.
No, whether there was any associated perhaps some abnormal hemoglobin. So it was not thought of at all.
It was not thought.
So whether this is just ongoing, no, but it is too
Whether it is just ongoing inspissated, that's
yeah,
too much of a stretch. Because the hemolysis is there, that's the reason. Because the child has been continuously having low hemoglobin, but that's not very massive drop. He's hovering somewhere between 7 or 8.
Yeah, but the DCT has been persistently positive. So if the antibodies were all removed, so perhaps if they had done an exchange transfusion, all the antibodies would have been removed.
I think so. Probably, maybe the exchange was done earlier rather than giving IVIG. Maybe the anemia would have been corrected.
Yeah,
that is what most of us.
I don't think an exchange was not done at all. It was only triple
exchange
surface.
was not done at all. It was near exchange, but since the bilirubin showed a declining trend in the first 6 hours to the neonatologist in that particular area, so he thought maybe we could conserve and give intensive phototherapy. But then he had to see a recurrent fall in hemoglobin, which was probably related to the late anemia of RH, which may be immune mediated or the hyporegenerative marrow secondary to the effects of RH isoimmunization. So that may be one of the reasons.
Yeah. So So are you giving us the answer, or are you asking?
I think we got the answer from Girish sir already.
Yeah. Okay.
So,
persistent anemia of RH income. Great.
So basically, baby was given furosemide, aldactone, glutamate, vitamins A, D, E, K. There was progressive distension. The baby was kept NBM, ascites was tapped. One blood was given, 2 FFPs were given. But most important thing was that, as Dr. Girish sir said, whether this was a biliary leak. And it did show that this was a bile which was there, biliary ascites. So this was a ruptured choledochal cyst, which was fusiform variety with choleascitis. Basically, we tapped, we put a drain, and after 72 hours of stabilization, the baby underwent a laparotomy, and it was seen that this baby had a fusiform dilatation of the common bile duct, and the common bile duct had ruptured on the anterolateral aspect on the right side. And that was the reason which showed probably a obstructive element of jaundice with high GGT and the hepatosplenomegaly, which was a combination of RH with intrahepatic obstruction, with cholestasis, which probably would have resulted in splenohepatomegaly and conjugated hyperbiliary. So I just thought before we summarize, we all know the right and the left hepatic duct. We know the cystic gallbladder cystic duct, which opens into the common bile duct, and it gets joined by the pancreatic duct to open into the ampulla of Vater. So there are different types of choledochal cyst. Our baby probably had a common bile duct which was dilated. There was no any intrahepatic extension of it, and this is how the biliary tree looks like. And our baby looked like a type 4A fusiform dilatation of the common bile duct, and it ruptured near this end, the right side anterolateral aspect, resulting in choleascitis or biliary peritonitis, which resulted in ascites and cholestasis. The liver functions were repeated on 15th of October, and it showed the SGPT had fallen to 127, the gamma GT reduced to 114, total bilirubin was 4.6 with direct of 2.8, and the INR was 1.1. The reason the drain was removed on day 6 post-operative period, left is improved, the jaundice reduced, the baby was feeding well, the stools remained yellow, and the baby was discharged at day 20 or day 80 of life. So basically what really we thought in this case was, it started as an RHIS immunization. The baby did not undergo any exchange transfusion. There was increasing hemolysis, which resulted in falling hemoglobin. The baby had persistently high indirect going into direct or mixed jaundice. But striking feature why we really did not think of any liver disease per se was, like Madam asked whether we looked at torch or whether we looked at any metabolic liver disease, but that the INR was fairly normal, number one.
Yes, INR remained normal.
And it remained normal. The gamma GT was fairly high as compared to the SGPT, which probably took us towards obstructive jaundice, which we thought initially as inspissated bile syndrome. 2 ultrasounds were done with us. 1 ultrasound was done with the referring neonatologist, and all the 3 did not show any abnormality of the common bile duct. And that is something which we thought we should really remember, that ultrasounds may not be able to give us the fusiform dilatation or a choledochal cyst. And what we really learned was probably having a very high index of suspicion that if the baby does have high gamma GT, yellow stools, or not having clay colored stools, not all high gamma GT are biliary atrasias. They may be biliary hypoplasia, they may be choledochal cyst, which are intermittently infected, and we do have waxing waning pattern of jaundice with choledochal cyst, which keep on presenting in our day-to-day practice, and they are picked up quite late at times. And also very important thing that we learned here was that hepatosplenomegaly probably was secondary to the anemia, with reticular with extramedullary hemopoiesis, and this jaundice, which we thought was probably a liver disease, turned out to be a cholestasis due to a choledochal cyst. So I thought it was a very interesting case. Well, I learned quite a lot evaluating this case, and I must congratulate Dr. Girish and all the esteemed panelists who really teased out a lot of information from this case. Thank you very much. Over to you, Madam.
Thank you, sir. That was a wonderful case. Dr. Samdani sir and Dr. Ambekar sir, can we have your comments, please?
Yeah, I think what was presented was when the baby was first time shown at KEM, the growth was reasonably good when the direct bilirubin had come in. And Sandeep said that 25 grams per day was the weight gain, which was not bad. Now, when you have a direct bilirubin coming up and the growth is reasonably normal, you start thinking whether it is a primary biliary tract disease and not primary hepatocyte disease. I think the major difference to me between hepatocyte disease and a biliary tract disease is a reasonable growth maintained till end in a biliary tract disease. On the other side, the hepatocyte disease would have faltered in terms of weight straight off. So first, when the indirect bilirubin became direct, I started thinking inspissated bile syndrome was what we learned in 60s, but that is not the issue. But I was wondering whether any blood transfusion gave some infection that caused a direct bilirubin. That was one thought. But when you saw a good weight gain, hepatocyte primary disease was unlikely, and you have a biliary tract disease. Now, if it was a biliary atresia, it should have started coming up pretty early. So possibly not that, but one would not have straight away jumped on to say a choledochal cyst, but I would have said biliary tract disease primarily. And I think one of them would be, say, biliary calculus. After the ultrasound has come into now easy use, one has seen gallstones even in infants of whatever etiology. I don't think hemolytic anemia is the common cause of gallstone now, but there could be many other things. So I was thinking whether it is going to be an obstruction in terms of maybe a gallstone. Okay, but as Dr. Subramaniam had already said that possibly a choledochal cyst. But the point I want to make is a direct bilirubin, you must differentiate between primary hepatocyte disease and a primary biliary tract disease simply on growth. And this was a primary biliary tract disease. Thank you.
Thank you, sir.
In fact, if you see that the direct bilirubin started rising subsequently, and when the hemolysis was maximum, the inspissated bile syndrome should have come at that particular time. But you started getting rise in the direct bilirubin subsequently, which clearly tells you, and the liver function being maintained, and the albumin being maintained, INR being maintained, it speaks of that probably there is some obstruction in the biliary tract. And therefore, the concentration at that level could have gone to biliary tract problems, along with the direct DCT, which was positive, which was related to RH incompatibility.
Yes, sir.
Amazing.
This was a case for two teams.
Yeah.
Thank you so much. Thank you, ma'am. Thank you, Girish Subramaniam, sir. Sir, there is a question by Dr. Rajesh Chokhani, sir, that why did you ask for
biliary ascites?
Biliary ascites.
To Dr. Girish Subramaniam.
As I said, if you have significant ascites in neonatal cholestasis in a newborn period, you have to think of whether it's an acute liver failure which can occasionally present in the neonatal period, or it could be biliary ascites. Don't forget biliary ascites. Uncommon cause, but a treatable cause of neonatal cholestasis syndrome. Spontaneous perforation of the bile.
Can, as a diagnostic modality, one can go ahead with the ascitic tap in this case, which would have perhaps solved it early?
Yes.
He did.
Bilirubin value in the ascitic fluid will help you clinch the diagnosis.
I think
just by seeing the color as well. Just by seeing the
I think
color.
most of us probably do not give so much of relevance to the physical examination of the ascitic fluid, and we just give relevance or importance to a lot of biochemical investigations. So I think common sense probably tells us that we tell our residents to do the ascitic tap and we just don't worry about it. I think it's a good idea to probably see the fluid and come to a logical or a reasonable diagnosis. And that is what probably would have clinched the diagnosis.
Neonatal liver failure is a rather uncommon entity. It can exist. We see so many neonatal cholestasis syndromes. Rarely do we come across with neonatal ascites because of neonatal acute liver failure. It's a big list of causes, including the condition that I was alluding to when I asked for serum ferritin, gestational albumin liver disease. But they are all uncommon, and at least we have not seen that very often. So if you look at biliary ascites in a neonatal cholestasis syndrome, consider at least the possibility of biliary ascites and proceed. It's a very easily treatable condition.
Spontaneous rupture of bile duct or a ruptured choledochal cyst are probably two common causes of biliary ascites, and I think that's not uncommon, but though rare, not uncommon.
Excellent, Dr. Girish.
Excellent.
Thank you, sir. That was really a very good, interesting case. Something very different, basic, and we learned that very good comments from Dr. Amdekar sir and Samdani sir. Can we go for Dr. I'll give over to Dr. Neha for the future proceedings.
Thank you, Shilpa. Now we invite for open comment if anyone wants to.
Girls from Case Challenge. You can make a book on it.
Yes. And I don't think this should be the concluding.
Yeah.
Yeah.
Thank you, sir.
Perfectly
One or two comments here. We start learning reading X-rays from UG days, but even at the end also, we still lag behind, I think. Because whatever undergraduate teaching of X-rays, we really don't follow that. We just try to spot it and then we miss it. This is what I feel.
Yeah, but that esophageal shadow was there. I mean,
right.
Yeah, it is there, but it was missed. It was missed by many.
Yeah.
I am saying this for the second time.
Because we were not allowed to comment, but that was definitely a marker, and the distension, the history of the child having persistent, because these are two important features. Maybe the coughing while feeding may be there in a edge type of fistula, but distension, a persistent distension, usually will probably lead to the diagnosis of edge type of fistula in that first case.
But Tide sir rightly pointed that there is something which is looking like intestine.
Yes, definitely, yes.
That was also a point to be taken.
Yes.
Sudhir wants to say.
Yeah, I think I really enjoyed this session. And thanks, Mahesh, and thanks, Mahapi, for conceiving this idea. It's an extremely good thing.
Yes.
And as Anjali said, it should not be the last. We keep on learning and we are students all our life. And I think it was excellent. I think thanks to both the moderators they presented, they must have worked so hard to get these cases and present like this. And really great. Thank you very much.
Only thing I want, still I am not able to explain is why this H-type fistula has a unilateral so much features. So if there has any previous history which show there is initially there is a bilateral, and then it one side is happen, or we can see this type of so much type unilateral symptoms in a H-type fistula.
We didn't have an access to the previous X-rays at all in this child. We didn't have any other records, unfortunately. But at times, the fistulas, fistulas particularly, can open in one side bronchus. Though here it was seen in the trachea, but at times you may see that opening in one side bronchus. Whether that can cause a localized or lateralization, I don't know. But in this case, it was in the midline.
And second thing, why this, if any record of 7 months weight, because his weight is much, he is, I think he is just 7.8 kg at 2 years with birth weight of 2.5 kg, and height is also very significantly short, only 70 centimeter at 2 years, which is significantly short, which cannot be miss. I'm not able to explain why this much of white and height shortening with, in this, whether he has any associated anomalies, miss, whether he has
No,
vertebral
clinically not,
anomalies
but clinically not, but if you notice, he was desaturating at room air when he came to us. So he was having a chronic hypoxia in this child. He had a chronic lung disease already set in for some time. He was desaturating at room air when he came to us. So it was, though it was intermittent, over the time it had become sort of a persistent problem. Had it been only unilateral, you don't expect desaturation, but this child had 92% saturation at room air, which is hypoxia. So that will definitely hamper the growth. And the must have started.
The important history is that during feeding, there should be a history of coughing most of the time in these H fistulas, which was probably not narrated or not identified or not asked for.
Going back after the diagnosis, we asked that, but there was no such correlation.
I think I also take that point that Dr. Abasai Patankar said, that we keep on learning, reading X-rays, but that's because as pediatricians, we see so many poor qualities X-rays that some of the things we just keep on neglecting as artifacts. And this is what we should learn now, that we could all see that shadow. And I in fact, Dr. Naresh gave it a thought saying that intestine. I saw that and I thought that it must have been artifact. It was AP view lying down with malrotation. So, we always blame it to poor X-rays, but that is one take-off point that we should try to kind of fit into the case. Yeah, Sandeep.
Sir, I might have missed. Mohite sir, was an echo done in this child? Echo, and did it show any evidence of pulmonary hypertension?
Pre-operatively, we did that.
Was there any pulmonary hypertension? Because the lung did look hypoplastic.
No.
The left lung did look
yes,
hypoplastic.
It was, but so, there was no pulmonary hypertension.
And was there any difference in the pulmonary artery measurements between the right and the left lung? Because if there is hypoplasia of the left lung, the pulmonary artery might have been smaller as compared to the right side. So was it seen by the radiologist?
I don't distinctly remember that, honestly. This was pre-op done on the bedside echo.
So maybe the scan, you could ask the CT scan or review, get it reviewed.
No. On the scan, it was a contrast CT and it was not mentioned of that kind, any cardiac anomaly.
No, pulmonary artery size.
Yeah, I agreed, but there was no positive kind of a mention of any disparity in the size. I agree with you that you do have some kind of thing, but it was not there. This X-ray was, in fact, I have this case in the SRCC meeting, and there Hiren Panwala diagnosed on the X-ray that this looks like H-type on the history and the plain X-ray. He said, if you get a duodenum visualized or a kind of a esophagus visualized on the X-ray, think of a significant gas in the esophagus, and probably the only condition where you get that is a good H-type fistula. So
what happened to this child after the?
There should not be any air in that. Esophagus is a collapsed structure. We hardly see on X-ray. There should not be air.
Don't see that.
If it is the air, it is 100% abnormal.
Mahesh, what happened to this child's X-ray after this child was operated after a few days? Because if it is hypoplasia of the lung, then that shadow would persist.
But once it is fibrosed, you don't expect that X-ray to recover. This, in fact, case was from Mumbai and was referred by one of the Mumbai pediatrician for bronchoscopy to me. And on the scopy, once we diagnosed, he sent it for operation also to our center. We operated this case. Most of the child did well, but of course he was following up for almost 6 months after that to me. And X-ray was almost, was not totally recovered, but it was underlying probably fibrosis. Even the CT was reported as collapse, and he had a clear bronchiectasis developed. If you could see that CT plate which I showed you. So it was some irreversible damage is expected out of it.
Yeah.
Dr. Mahesh, this is Dr. Kinika here.
Yes.
Just wanted to tell you that we always forget that with TO fistulas, H-shaped, there are a lot of tracheal anomalies and esophageal atrasias. And that is associated usually on that side with lung hypoplasia of varying grades. So your SpO2, which remains so low, is not just because of the H-shaped fistula and the fibrosis, because diagnosing fibrosis is very difficult by a radiologist. They will always tell you correlated clinically, but SpO2 of 92, and it's a known fact of associated anomalies. So if we can do a VQ scan, subsequently, if the patient comes back to you, probably it will tell you that there was a problem that time and it has grown. If you look at the trachea in that X-ray, that is also showing an anomalous bend or coming to the left side, and it is narrowing over there.
So it was not a very well centralized X-ray, and that kind of bend we have seen time and again, even in the normal child also. So
No, it
I
is
would
too
not
acute.
give big
It's
weightage
too
to
acute. It's almost 90 degrees. You don't see it that way, unless there is a hypoplasia.
Naina is my registrar, so I can't comment.
Come on. I have Dr. Samdani sir and Ambekar sir there.
Yeah, so I can't debate Naina. I'm still scared of you.
Oh my God.
There are two things in the X-ray. If you see, the stomach was also dilated comparatively. And also you see a straight line. The intestines will never give you a straight line. These are the 2 pointers against an intestine being in the chest.
Yes, so after both the moderators have presented so wonderful and unique cases, and there are so good discussion still going on among moderators and panelists. Now both the teams did excellent. Congratulations to all of them. And with the golden words coming from our experts, both the expert was icing on the cake. Now we proceed toward the vote of thanks. And for this, I would request our Maha IP State Convener, Dr. Jay Bhandalkar, sir. Over to you, sir.
पहिल्यांदा सगळ्यांना मराठीतच बोलतो. आज दिवाळीचा पहिला दिवस आहे. खरं तर फटाके फायर क्रॅकर्स फोडायला पाहिजे. ती म्हणेल की द नॉलेज फायर क्रॅकर्स वॉज दो वी केम टू द डायग्नोसिस इन बोथ केसेस. म्हणजे डिस्कशन होतं त्यामुळे आय थिंक वी केम अक्रॉस 100 ऑफ क्लिनिकल डायग्नोसिस देन कम टू द डायग्नोसिस. तर सगळ्यांना माझ्याकडून आणि आमच्या महाआयपी कडून सादर प्रणाम. आणि सगळ्यांचे मी असे आभार मानतो की असंच हे चालू ठेवा, बंद नका करू. ह्याच्यासाठी की वाटतं हे शिकणं जे आज मला काही नॅशनल प्रेसिडेंट म्हटले की डॉक्टर मध्ये साहेब तुम्हाला काय वाटतं, म्हणजे मी ऑफ द रेकॉर्ड बोलतो, वोट ऑफ थँक्स पूर्वी. फर्स्ट थिंग आय लर्न अ लॉट. आणि हे लर्निंग असंच चालू राहतं त्यामुळे मी यंग दिसतो. आय एम ए व्हेरी नॉट एन एजेड. नॉट डॉक्टर कधीच एजेड दिसत का दिसत नाहीत, कारण सारखं विचार करतात म्हणून. तर सगळ्यांना मी पहिल्यांदा समदानी सर आणि आंबडेकर सरांना आमच्याकडून धन्यवाद की त्यांनी मी लास्ट एपिसोड कधीच म्हणणार, कारण आपण मला वाटत नाही की लर्निंग कधीच लास्ट असतं, कधी थांबत नाही. हे असंच राहावं. आणि आपले फ्युचर, मी नाव घेणार नाही, परत आपले थोडा आचारसंहिता आहेत, महाआयपी प्रेसिडेंट जे पुढचे आहेत हे असंच हे कंटिन्यू राहणार आहे. आणि आपले पहिल्या केसेसचे मॉडरेटर आहेत डॉक्टर मोहिते सर आणि 3 एक्सपर्ट साने सर, तायडे सर आणि चोकानी सर, ह्यांचे पण धन्यवाद. नंतर सेकंड केस चॅलेंजचे आमचे एक्सपर्ट, आमचे मित्र संदीप कदम, त्यांना पण धन्यवाद. आणि 3 एक्सपर्ट अंजली गोकर मॅडम फ्रॉम पालघर IIP, नंतर नानोडी सर फ्रॉम कोल्हापूर आणि गिरीश सुब्रमण्यम सर, या सगळ्यांचे परत धन्यवाद. आणि 2 महत्वाची माणसं मी घेईन जे मॉडरेटर आमचे आहेत, नेहा सिंग आणि शिल्पा, कारण हे एवढं सिक्रेट होतं की आमच्या कुणालाच माहित नव्हतं. म्हणजे सो सिक्रेसी मॉडरेटरला माहित नाही, कोणालाच माहित नाही कोण प्रेझेंट करणार आहे, काय प्रेझेंट करणार आहे. सो सिक्रेसी एवढी खरं तर आपल्या इथे कशी होते, आणि असं कोणीतरी म्हटलं की का राहणार, पण दिस इज द रिअल चॅलेंज टू मेंटेन द सिक्रेसी ऑल्सो. So thanks to all of them and Pallavi Dharmadhikari for the excellent digital support all over a year, and I think that will continue also. And thanks to our own team, Vishal Raut, I never forget him. Almost he had done 500 flyers for the MahaAP, excellent flyers. And again, त्याला जोडून जे मेसेज येतात from Neha, excellent messages, properly done. And I thank our own team, आमचे अध्यक्ष असं म्हणेल डॉक्टर हेमंत गंगोलिया, ऑलवेज सपोर्टिंग. जे काय करायचे सांग नवीन, तर आम्ही नोव्हेंबरमध्ये थांबणार नाहीये. काही फार नव्याने गोष्टी करतोय. आणि तर प्रत्येक जण महाएपी युट्यूब चॅनल पण बघा ना, ते प्रोग्राम्स अटेंड करा. आणि क्या कहणे हमारे अमोल जी का, की सारखे अरे बिझी आहे, आपले इलेक्शन्स आहेत, पण काम करायचं आहे. आमचं सगळं बोलणं होतं. आणि ऑल टीम ऑफ महाएपी, म्हणजे विनायक पाटील, देन आमचे ट्रेझरर मोहन, आणि ऑल वुमेन बिंग, ऑल EBs, excellent work done by them over the year, and thanks to the all paid team of the Maharashtra IP, all branches, they supported very well to us. म्हणजे खरं तर विचार करण्याच्या पलीकडे वाटतो मला काय हे जे वर्ष चाललंय हे खरंच थांबू नये आणि लर्निंग हे असं चालू राहावं. तर सगळ्यांना तुम्हाला दिवाळीच्या शुभेच्छा. आणि पहिल्याशी फटाके वाजवायचे असतात, पण मिळेल की कधीच असे जे फटाके अकॅडमिकचे आहेत, and when we are the great I think opportunity given the God to work for the kids, हे जे याच्यासारखं मोठं प्रोफेशन जगात कुठलंच असू शकत नाही असं मला पर्सनली वाटतं. लिव्ह अपार्ट द अदर आवर, म्हणजे ऍज अ मनी मेकिंग बिझनेस आय कॅन से, अदर कंपनीज अदर ब्रांचेस, पेडिक्स कॅनॉट बी कम्पेअर विथ एनी ब्रांच. मला असं पर्सनली कधी वाटतं, बिकॉज वी टेक केअर ऑफ द किड्स, वी आर द फ्युचर सिटीजन्स ऑफ द वर्ल्ड. सो थँक्यू व्हेरी मच. सगळ्यांना परत मी धन्यवाद देतो. आणि कुणाचं नाव जर राहिलं असेल तर क्षमा असावी. आणि असेच येत राहा. आणि फक्त आमंत्रण दिल्यानंतर डायस सुरू नका, असं न आमंत्रण असताना पण सिनियर्सनी यावं आणि गाईड करावं. एवढं खरं सांगेन की एक स्टोरी, पण वेळ नाही माझ्याकडे. आंबेडकर साहेबांनी सांगितलं की हेपॅटोसेल्युलर डिसीज, पेशंट ग्रोथ फेल्युअर हा बिलियरी ट्रॅक्ट डिसीज आहे. हेपॅटोसेल्युलर कारण पेशंटची ग्रोथ बरोबर नाही, डायग्नोसिस तिथंच झालं. इम्युनोडेफिशियंसी सामने सांगितलं तुम्ही वो देखो कुछ पूछो फैमिली में कोई डेथ हुआ है क्या, टॉन्सिस देखो, इम्युनोडेफिशियंसी उधर ही रूल आउट हो गया. सो दॅट इज अ बेसिक, म्हणजे की खेळा मारायचा तर मी खेळा मारायचे ₹1,00,000 घेतो, कुठं खेळा मारायचा म्हणून मी ₹1,00,000 घेतो. हे जे की स्टोरी प्रत्येकाला माहित असेल. तर थँक्यू व्हेरी मच. आणि मला आता खरं तर एअरपोर्टला जायचंय, का मी नंतर सांगेन.
Thanks, Jay. And I thank each and everyone to justify the theme of the year, the share the vision, and everybody and has shared their vision throughout the year. Thank you very much, each and everyone.
Thank you.
Thank you, Mahesh. Thank you, Mahesh, for this brilliant idea.